Hello, and welcome to today's virtual program hosted by the Healthcare Council of Chicago, HC3. My name is Meghan Phillipp, and I am the Executive Director of HC3. We are a mission driven platform convening Chicago's healthcare leaders and stakeholders to address issues and barriers that our industry faces. As we continue to navigate the ongoing COVID-19 pandemic, HC3 launched the Transformation Series to address how we can leverage our collective resources to foster solutions and help rebuild our communities. Today, we are joined by leadership from three local hospital systems to weigh in on the financial impact of COVID-19 and how they are focusing their efforts to recover and rebuild. Before we get started, I have a few housekeeping items. This afternoon's discussion will be recorded and shared on our website, www.hc3.health. As we hear from today's experts, if you have any questions, please feel free to use the chat function, which you will see directly below on your panel, and it will be seen by our panelists as well as our moderator, who will do his best to address these during our audience Q&A later in the program. So without further ado, I would like to invite our panelists to turn off their cameras and unmute themselves and welcome them to our program today. So Dominic Nakis, who is the Chief Financial Officer at Advocate Aurora Health, Richard Silveria, who is the Executive Vice President and Chief Financial Officer at the University of Chicago Medicine, Doug Welday, who is the Chief Financial Officer of North Shore University Health System. And last but not least, it's my pleasure to hand things over to today's moderator, the President and CEO of Health Financial Management Association, HFMA, Joe Fifer. Thank you all.
Well, thank you, Megan, and hello to everyone. Myself, I'm just really glad to be here today. Just getting organized, this reminded me that I was involved a few years ago when HC3 was originally conceived and brought together, and I'm just thrilled that that has been a real powerful influence in the Chicagoland area. Just a brief comment about HFMA, if you're not familiar with HFMA, but we're a 64,000 member professional society type organization with all kinds of content and certifications and those things that you would expect from a professional society entity. So we are located in the Chicagoland area and but obviously service the whole country. And today I'm really honored to host this episode or this event with three folks that I would consider friends. They're CFOs of I was going to say local systems, but they're very broad in their geographic coverage. Interestingly, this is a second event I've done with these three. We did one a few weeks ago or so with HFMA, and I don't know, guys, maybe this time we'll get it right. But anyway, it's great to be here with all of you today. And just for the audience perspective, I'm going to ask a broad range of questions. I know this is talking about the economic impact, but I got to tell you, CFOs do way more than just balance books in their organizations. They get involved with all kinds of operational issues. And so we're going to dive into a number of different issues that on the surface you might think don't have anything to do with finance. But I have an old saying that, as I used to use as a CFO, that that almost everything has something to do with finance that enables me to stick my nose into just about anything. And so it's in that spirit that some of the questions I'll get into today are pretty broad ranging. And so with that, gentlemen, maybe we'll just jump right in. And how I'm going to do this for the audience sake is I'm going to ask a question and I'll pick on one of them. I'm just going to kind of go at random, have one lead answer to that question. But we've encouraged them to have some dialogue about it and chime in in addition to that. So again, just purely randomly, Rich, I'm going to start with you on this first one. And it's all about something that we're all feeling in our general lives, this whole pandemic fatigue. It's happening everywhere. Chicago is no exception. Burnout is within the health system is leading young physicians of all types, nurses, other healthcare professionals to consider leaving their jobs, leaving the field altogether. I have a daughter who's a PA, not in the Chicago area, but she tells me that she talks to some of her colleagues in her health system that they're dedicated to stay through this pandemic, but as soon as it's over, boy, they're going to go. You know, a lot of it is due to the stress of treating COVID patients, et cetera, et cetera. So with that as a backdrop, Rich, maybe you could just lead us. How is the pandemic fatigue impacting your team and your organization from your perspective?
That's a tough question. I wish I had a great answer for it, Joe, and good afternoon, everyone. Sadly, it's inherent with this pandemic that, our frontline workers are putting themselves in harm's way. And I think the first thing is to treat them like the heroes that they really are. In the first wave, we also dealt with supply chain issues with personal protective equipment. And, we collaborated with many of our colleagues here to say, how do we acquire, maybe there was large batches of material. We're trying to get it from China. The prices were skyrocketing. And you're dealing with phone calls from physicians and nurses that say, I don't care, I need this. So it was stressful for everybody. But in terms of, what have we done as a practical matter? We have EAP programs, I'm sure we all do. We try to be visible, and say thank you. Holidays, it's not a, something that really lasts, but you did say thank you with a holiday recognition bonus to our staff. I think I hope it is probably the worst of it right now, because it's not just work and the pressure of work and folks that aren't on the front line, the isolation of working remotely and not having the collegial relationships that you're used to having, but you're also isolated from your family and your loved ones and whatever activities you like, whether it be the theater or whatever it is. So I think it's particularly bad, but we throw, the EAP program and make sure that folks understand that. We've staffed up in areas. We've brought in agency, which is travel nurses that come from outside of the region. That's very expensive to make sure you have adequate staff because of the acuity being up and the length of stay being up. So I wish I had a better answer other than to say that you're here and you're trying to support them and make sure it's not something that's done episodically, but it's done kind of regularly and consistently.
Doug and Dom, you seen the same thing in your place?
Yeah, from my perspective, we've seen the same things. And good afternoon, everybody. I would echo what Rich has said, and in addition, we do have to recognize the heroes that are providing the care. And I feel like when you look at it over the past year, certainly there was the stress in the beginning of just the unknown and the demands that put on the caregivers being on the front line. And then as this pandemic has gone on for the next year, we've had the spike in the winter season, and you put on top of that just the stress, the other stresses that as a society we've gone through over the past year with the social unrest in the summer, and then the political elections. It's a lot. And I think from our aspect, things we've done in addition to what Rich has indicated is, one, I think you have to acknowledge it and tell the caregivers, because sometimes you just want to be heard and give them opportunities to provide feedback. And we do that through a lot of rounding within our departments and town hall meetings. And the other item during this pandemic, I give credit to our CEO, Jim Skogsberg. He started from the beginning of this pandemic, weekly videos that were pushed out across the organization. People could kind of do it in their own time. And he addressed all the items up front and told people what was going on and what we were dealing with, whether it was staffing shortages, how are we addressing that through contracts with temporary agencies, what we're doing in the supply chain area to help provide them the tools to protect them. And he would also end his videos with a statement that was calm over chaos, faith over fear, and try to give a positive attitude and perspective to folks, to say we're going to get through this pandemic. But the burnout is it is a very real thing. It's difficult to address.
Sure. Doug, anything from your end on that?
It's really hard to add a lot to that. You know, I think the North Shore organization is doing a lot of and dealing with essentially the same challenges that Rich and Dom described, and taken much of the same actions. I think really importantly, a couple things just to highlight is similar to what Dom had described, is really pushing information to staff on a regular basis through a variety of channels, letting them know what's happening, you know, what the data is, what they're faced with, et cetera, and keeping them in the loop, both in terms of what's happened, but also the vision of the future. And we really are very much at this point focused on the future to try to address the fatigue, thinking about the light at the end of the tunnel, so to speak. And then the other thing that has been throughout the entire pandemic is, you know, we established right out of the gate a series of guiding principles around how we were going to address it. You know, like in many respects, like the firefighters who run into a burning building, our heroes, you know, ran into this challenge right out of the gate and have been fighting this very effectively for now going on 12 months. But we really established a principle that first and foremost, our attention was going to be around patient and staff safety, and making sure that we were going to do whatever it took to not only provide them as safe a working environment as possible, but also the resources necessary, both in terms of whether it's PPE or staffing, et cetera, necessary for them to be safe. And I feel actually quite proud about how we were able to handle that. And frankly, we've had a remarkably, considering the circumstances, we've had a remarkably low number of our staff and our team members that have been infected with the virus and have been it's been quite amazing. And frankly, it appears that most of them have been community related and not based on contracting it in their work, which has been really helpful for our teams to understand what their risks are and to be able to manage their personal perspectives on dealing with this.
Yeah,
we could talk about this for a long time, but I'll stop there.
No, that's good. And I do have a follow-up question, but both in the preparation calls and then today, several of you used the term heroes. And I just want to reiterate for folks in the audience, if you're not tuned into what goes on inside these hospitals, that term is not being used lightly. These folks, and I'm a little biased because my daughter works in an inpatient facility. They really are heroes. What they go through to take care of folks, their hearts are huge. They sacrifice. They really are heroes. So I just want to reiterate that. But I did want to follow up, Dom, and I'll pick on you first. You talked about shortages and you talked about travelers, and I want to dive into that a little bit and turn this into a little bit of a financial conversation, more than perhaps just on pandemic fatigue, but the whole environment of getting travelers, those are nurses that that come in, and other healthcare professionals that come in for a certain amount of time, 3 months or so. Some of these travelers go around the country doing this, and they fill in, and it provides for, in a normal environment, provides for great flexibility for a health system. But in this environment, it takes on a whole different meaning. And so I just wanted you to maybe talk about, have you had major increases in the cost of travelers or contract staff? Just talk about that environment a little bit for our listeners.
Sure. We certainly have had increase in cost using travelers, and it not only comes in the form of the rates paying for those nurses, but also in terms of commitments that had to be made, because there was such a demand for nursing care during this time period that the was just frankly a supply and demand issue, and the peaks hit particularly in the latter part of 2020, just all across the country. So the demand did drive up the price, and you saw that also in the supply chain area when it came to PP&E and certain of the drug costs that were maybe being utilized and at times in caring for those patients. And I'm going back to the beginning of your description of the CFO job. Almost everything touches finance. So from that standpoint, we certainly see it. But during this pandemic, one thing we tried to do in our organization is defer to the expertise. And when the pandemic's going on, there were a lot of times I just got out of the way. Just whatever the cost was going to be, we were going to pay it because it is safety and quality first, and the taking care of our patients. And I don't want to come off, hopefully I'm not coming off glib on that standpoint, but at least the three of us here, our organizations, came to the pandemic in fairly good shape with solid to strong balance sheets, and from a finance standpoint, that helped carried us through this pandemic.
Yeah, I don't think it's glib at all, Dom. It's the same attitude I heard all around the country, and in fact, sometimes it was when you think about how health systems organize around crises. Sometimes it's literally just getting out of the way, right? Staying out of the room and letting people take care of people. So I don't think it's glib at all. Thoughts on the travel environment for either of the other two?
Well, I would say that, we had a modest amount of traveler and outsourced nursing and support staff. We were very fortunate to be able to keep that relatively modest. And I think a lot of that was our teams did a really great job of redeploying people. As most know, our business activity was, for the non-COVID patients was impacted and reduced. And so we were very fortunate to be able to create what we call the labor pool and have people sign up for additional work and additional shifts, et cetera, that significantly minimized the amount of outside resources that were required. We did as similar to what was done at Advocate Aurora. We did provide additional financial incentives for folks, and additional commitment pay and those types of things that made it attractive for folks for staff members to step up and take on extra work. And again, as I said, going back to the earlier comments, that with confidence that they would be safe and that they would have the resources necessary to deliver outstanding care.
Just add a little bit. I mean, it's been said. It's really the safety and the quality. And in the early days when we weren't sure about the duration of the incubation period, and there was some uncertainty, and people may have been exposed, we would quarantine out of abundance of caution and bring in either overtime if people wanted it or agency. So we definitely saw an increase at our community hospital. And Don, maybe you saw this, and Doug as well. You're working side by side with an agency, and they talk about what are you getting paid, and so that kind of increased our cost, because we had some nurses and say, well, look, I can make some extra money for my family, and I'm going to go do agency work. So we ended up losing some staff to that. I think it will probably correct over time, but that was an impact as well. But the rest of it's been said.
Yeah. Well, thank you. That's all very interesting. I want to move on, and this is one that's even more finance oriented. And that's directly related to the financial impact of the pandemic. I know recently the Illinois Hospital Association, in a bid to gain additional federal pandemic relief funding, pointed out that hospitalizations during the fall and winter surge were almost twice as high as during the spring surge in the Chicagoland area. And I know that's the case in a number of places around the country. And additionally, the treating COVID-19 patients has become more expensive, widening the gap between what hospitals spend to provide care and the payment they receive from payers. So with that as a backdrop, and that's just a microcosm of what a crazy year from a financial perspective that you've all been leading the charge on. I have a two-part question. One is this environment caused you to change your financial planning and forecasting strategies? And then secondly, related to that, what kind of either cost reduction pivots or, other ways to enhance revenue pivots do you think about for the next 12 months to make up for lost revenue or, need to delayed and canceled procedures and, those kinds of things? So two-part question. One's about financial planning and one's about just how do you react to that? So Doug, you're first up this time.
Okay.
Thoughts on that one?
Well, first I'll talk about what we did or what we've done, what we're doing, and then it's certainly at the outset of the pandemic a year ago, and similar to what my colleague said, we just kind of got out of the way and told them do whatever you need to do. I recall getting phone calls from our supply chain folks pretty much every day telling me about how much this stuff was costing. And finally, I'm like, I really don't care what it costs. Just get whatever you need. Then we had the shutdowns of the services, which really created significant financial burdens, both the burden of taking care of the COVID patients, but also the financial burden of not being able to provide other services and generate the revenue. We pulled pretty much every lever that you would expect: furloughs, mandatory time off, compensation reductions for certain non-clinical staff, retirement plan adjustments, et cetera, and capital freezes, if you will, or deferrals. And so every kind of trick in the book we took to try to mitigate those costs. And then as we saw, and as we received the benefit of the CARES Act and the provider relief funding, that allowed us to bring back some things and allowed us to reduce the exposure, although it certainly didn't eliminate the overall impact or offset the overall financial impact to the organization. We've now, since we reopened since we've been providing elective services and operating in a more normal environment, we're back to about what we would describe in the mid to high 90% of the pre-COVID activity and patient volumes. And so now and we were planning for that as we got into the fall of last year. Our planning process is now a much more rapid cycle in terms of quarterly reviews and quarterly planning and restating our expectations. We are putting in place pretty aggressive staffing models, et cetera, to assure that we're staffing to demand effectively and being able to get ourselves back on the same financial footing that we were a year and a half ago. We did see, and in terms of planning for this, we did anticipate a longer term downturn. We implemented things like a voluntary early retirement program and other activities like that. And we were fortunate. We did not see, we had furloughs. Those people are back. We had mandatory time off. Those people are all back. We had voluntary retirement. Several positions were eliminated, but we were fortunate. We have been now a year into the pandemic. We've not had any involuntary layoffs as it relates to this, and through just aggressive management of the overall labor force and other supply and service arrangements over the course of the last year. So I feel pretty good about where we sit here today. We're not back to where we're not back to where we were a year ago when this hit. But I'm very bullish on the future of the organization and all of our health systems bouncing back effectively.
Yeah. And that's so important. What people don't understand, and one of you made this comment earlier, Dom, you said to me, all the systems went into this with a solid balance sheet. And I know, there's a lot of people in our society, they get really mad or don't understand, why hospitals, quote, make so much money, but you want our hospitals to be strong because of situations like this. Organizations like you all across the country, were able to do what you just did, step away as CFOs and say, hey, whatever it takes. And it was not creating organizational risk. You had the balance sheets to be able to withstand it. So,
and I would just add to that, Joe, that, all of our organizations in, February and March of last year, we saw this coming. We started making plans for it. And we're making the investments and, doing what was necessary, that long before we had any kind of assurance that we'd see governmental assistance.
Right.
These organizations, my colleagues on the call today, and dozens, hundreds of others across the country, we said we're going to do what is necessary, and we'll sort it out later.
Yeah, and quite frankly, the peaks are much higher of COVID patients are still higher than they were back in the spring. So the hospitals were virtually empty back then, and you went into it pretty blindly financially. So, Rich or Dom, any comments on the whole financial planning and cost management, revenue enhancement question?
Good, Dom.
Sure. We certainly did some things, tried to defer maintenance to reduce operating expenses. There were other, cost management techniques in terms of going back to our vendors and negotiating rates. We did. We cut a significant amount of capital, and there's other capital projects more in the ambulatory space that we've delayed, and now we're reevaluating them in the context of what healthcare might look like going forward. Do we have to change the size and scope of some of our ambulatory facilities, as perhaps there's going to be more telehealth out into the future? I do feel good that in terms of our staffing cost and benefit plans, we did minimal there. We did not change any benefit plans. We did furlough people early on when the pandemic first hit in that March, April, May timeframe. When we did furlough them, we continued to pay them at 100%, and what we began to phase some of that furlough pay down to 75 and 50% in the June timeframe, give or take. And what we saw is that as our business started to come back, we were then able to call people back from furloughs. So the cost reduction from furloughing people was very minimal, if almost none. I would say now, after we've been back to through this second peak here over the past few weeks, as the volumes have come down of COVID patients in-house, is much like Doug indicated, we're starting to reinstitute those productivity measures and say we need to, begin to adjust our staffing to demand. So some of those muscles, kind of went away over the past year, and we need to get back to them and to adjust to new levels. We did build our 2021 budget not to hit the pre-pandemic volume levels, and we're coming a little bit short of budget, much similar to the levels Doug indicated, except in the pediatric areas where we've seen some significant reductions in some of the particularly ER visits in the pediatric area, and as kids are not in school and playing sports or just having fun out in the backyard. We did, much like Doug indicated last year, we're really updating our financial forecast almost every other month to every quarter, and doing it more at a high level. That's a system consolidated basis. And I would say one of the areas for us to improve upon is to move to more of a rolling type budget on a quarterly basis. And we have some challenges given our recent merger. We have to complete an ERP implementation. And once that's done, the implementation of a rolling type forecast is first on our list.
Mm-hmm. Rich, anything to add?
Right, I guess, like my colleague said, I think we all got out of the way. Initially, when we were looking at, mid-March to like mid-April, and just kind of looking at the burn rate in terms of loss of EBITDA cash flow if we didn't change, we were looking at about 80 million a month that would come off our balance sheet initially. Yeah. So we did a number of things, hiring freezes for non-patient facing. We drew on we just thought about the financial crisis and liquidity lockup. And so we drew on our line of credit, not that we needed it, but we want to make sure it was there. We actually maxed it out, then we paid it back. We got another 100 million. We just wanted to make sure we had the money to pay the bills. But I would say we also took a broader look at what our role is in the South Side of Chicago, and all of our roles as healthcare providers. We're major employers. A lot of people's livelihoods are dependent on us as employers. And so we didn't do a layoff right away. And I'm like watching the cash go out and just trying to hang in there and trying to pay attention to what was going to come available. It was May or so before we knew about CARES and FEMA and how that would work. But we decided, people were going to go home, but we paid them 100%, just like Don. We weren't going to do a layoff, at least not until we got to dire situation. We did in May say, look, we need you to start using your earned time and your PTO time and at least get rid of it. And fortunately, our clinicians looked at, the executive order, no elective, but we looked at, well, there's still some things that we need to still do here, like, cancer surgeries, or, if a tissue match comes up on a transplant, we've got to do the transplant. And so our clinicians really, so how can we safely deliver care? And so they looked at cohorting the COVID patients and having separate entrances and egresses for them, completely separate staff. And then we started doing transplant, cancer surgeries, things that really needed to be done. And even towards the end of April, we started to see things come up a little bit. By May, we were kind of like 50, 60%. And by June, we were back like 90, mid-90s, and we've been there since. So we've not had to defer care. We don't cohort anymore. But we did a number of things. I mean, the executive comp, really more in the incentive comp, but still that's cut. And so we haven't restored that. We hope to be able to restore that. We stopped funding retirement. I'd like to restore that, but we were with the university. And actually, this has impacted the universities worse than healthcare. They don't have the same kind of CARES money. So, but we've been looking at, we immediately did it, went to like a cash flow model and looking at cash like right away, sources and uses, looking at that. Many of our board members are business folks, some of them in private equity, and my finance committee chair is a private equity guy, and he was asking me all about cash. So it was all good advice. So we focused on that. we focused on maintaining, quality and safety and the esprit de corps that was in the first question. We have a flexible budget. I want to get a system that actually maintains it. We're moving to a no budget system, but that's not fully, so we're on spreadsheets. So we have a plan, but every month you have kind of your actual to your original budget to your flexible target, and where are we and where are we heading. And then we also identify what other levers would we have to pull, if we have to. As we look forward, we're looking at telehealth. I mean, there's some good things that came out of this. I mean, the fact that you can render care to folks who might have difficulty being ambulatory and moving around, elderly or whatever, behavioral health. So, what's the prevalence of that? It's running around 20%. What's the impact on that in terms of, when you have folks, you use an analogy, the kind of the impulse buys are in store where you always have tests and things like that. So what does our revenue stream look like now, where you have less in person? But it's also an opportunity because, if the state laws can catch up in the division of insurance frameworks where it's kind of state-based DOI oversight and then state licensure, you could start thinking and imagine an economy where you might be able to do, how do a rapid consult in suspected cancer? Can we grow the pie? You have more capacity. Maybe you don't need to build that. So those are the things we're thinking about, is like, what's the prevalence? What will the rate be? Initially, it was kind of a lot of heterogeneity in terms of the way the payers would or not pay for it. The rates were always lower. Are they going to continue the in-person rates? The other, I think good thing that came out of this is people don't necessarily have to spend a lot of time in their car driving. So we're looking at, a remote workforce. I know we have a question on that, but looking at leases and OpEx and can we do things different? So, I guess the other thing I would just say to the audience is like the role of the healthcare we talked about as an employer and many times pillars of the community, but when you're sick, we try to make you better. And now the society is saying we can't afford that. You got to try to help us get better, population health, keep people well, but also be there when things like this happen. I was in the Boston market, and sadly the Boston Marathon bombing occurred and we were just flooded. And I think we had 5 or 6 trauma centers at the time. And you might look at that on a given day and say, like, why on earth do you have, it's good. It's like insurance. You don't need it till you need it.
Right.
So, the relentless push to affordability does not, I think, recognize what we're here for. And we're here to maintain capacity at the ready and be able to be here in these crises. And I hope this doesn't happen for more than a century, but I just think as we're business communities, we just have to realize that. And when you think about mRNA and, genetic engineering, I mean, when I was at Partners, we did this with the Harvard Partners, Genetics and Genomics. The fact that we're able to build messenger RNA, and that comes out of academic medicine. And so you say, well, these prices are high. We can't afford to pay for teaching and research until you need it. Yeah. So I guess that's what I would say is it's you can think about the spot market and I want to get the cheapest MRI. And that might be in the short term the right answer. I don't know what the right long-term answer is. We just going to need to think about is how do we prepare for these eventual things that are going to happen, and how do we innovate as a society in this space? So that's what I would say.
Rich, you just turned this 1 hour thing into a 5 hour conversation. I love it. But, those are really, really good points. And I think there's something that I think our society would be better off if they were debated in a factual, objective way. But that you're right. Or,
I think it's a tyranny of the budget. Like, we're all finance people. You got to make it work. So you look to cut, but then when you take the longer view, sometimes you don't always anticipate the downstream impacts.
Yeah. Well, you could make a correlation to, the energy environment in Texas, and, it looked one way on one week, and then the next week it all looked a little different, and you make the same argument. Hey, I should have said this in the beginning to the audience, and I forgot to. I apologize. But one person posted a question, but you could post questions either in the chat room or the Q&A. And I don't know if guys, if you see this, but there is one question posted. But before I get to the question, if you have questions, please post them. I'll keep track of them. And if they relate to one of the questions, I'll get to them right away. Otherwise, we'll carve out a few minutes at the end. The question, I don't know if you guys see this, but how are you looking at future remote work for the diverse functions of your teams, given what got involuntary done during the pandemic? So you sent people home, probably a lot of revenue cycle people, other non-patient facing people. Have you brought them back? Are you going to continue with a work at home environment? What are you doing there?
Anyone in particular? I could take it. I
We're-
mean,
yeah, go ahead, Rick.
We're looking at kind of tranches of employees. Your patient care, you have to go in.
Yeah.
But then there's some folks that can be hybrid that go in now and then there's some that could, essentially work from home permanently. One good thing, we had good systems and good metrics to measure productivity. Revenue cycle has not missed a beat. We were concerned that the payers might not be staffed, but fortunately, I think we've shown that we can get work done remotely. I do think there's, kind of a human impact of just the collaboration and kind of the esprit de corps I mentioned, but we're looking at that. I think, there'll be corollaries, I think, in commercial real estate. I think this is something that's here. I think you can do it. We're looking at, people don't have to, the expense of cars and gas and things like that. But I think there's a state law I'm starting to get familiar with in terms of compensation for connectivity and things at home. But we're embracing it. I think that, our staff appreciates it. I think it's harder for people with younger children that,
Yep.
Need to, help them with school and do work. So that, you have to be sensitive to that. But I think it's a positive thing largely, and we want to give folks flexibility, and it's also a savings for our employees, and I think ultimately a savings for us in terms of how we could repurpose space or not have to lease space.
Absolutely. Yep. I don't know, Dom, are you going to chime in on that one?
Yeah, I was going to say we're similar to Rich. We're going, we're calling it our workforce forward, and our philosophy is going to be remote first. That's what we'll look to. We've begun to reduce our real estate footprint. We had leases expiring at the end of last year. It's one of the areas that we can save funds. We're finding positives from it. People certainly enjoy the flexibility and the time it gives them when you take out the commutes. And as we know, living in Chicagoland, those commutes can be quite long. Though we're looking at it as a balance. I do see it's probably going to be a hybrid for a lot of people, where they'll be in the office 1 or 2 days a week, so they can meet with their fellow team members, get project work accomplished on an efficient basis, and we do think that'll continue to help maintain a good work culture moving forward. There certainly are some challenges for folks. People in certain positions may not have the right connectivity at home, or the home is crowded, and we've run into some of those challenges for folks also. But we certainly are looking at remote work being the way to go from the future. For higher level positions, we just feel that it opens up just so many more opportunities. You can recruit from across the country and not necessarily have to tell people they need to relocate to Chicago or Milwaukee in our case, or elsewhere for a number of jobs. So certainly some positives from it. I think Rich, earlier began to touch on what are some of the positives that have come out of the pandemic. We at times can focus on the negatives, but telehealth, a more flexible work environment are two of the positives that that have come out of the pandemic.
Sure. Yeah. Anything to add on that one, Doug?
No, I think
That's
we're
pretty
all
comforting.
in a bit of the same boat. You know, we don't yet have a rock solid long-term plan, although I do believe we will end up with some sort of a hybrid model. We're looking closely at our office spaces right now, lease consolidation, you know, elimination opportunities, converting workspace into hoteling space for folks that are working either partially or a majority at home. But I think what has been really remarkable, for me at least, but I think for many, is how smoothly we've converted to a remote work environment, not only in not only at North Shore, but I think at many organizations that, you know, our productivity, at least in the people that I deal with, both, you know, in the financial arena, but others in other areas, productivity remains, you know, very good. We're getting the work done. We're maintaining the level of service that our colleagues expect, et cetera. And so that's all been very positive. I do think on a long-term basis, we do have connectivity, not internet connectivity, but human connectivity challenges that we need to figure out how to address more. You know, we've kind of let that slide, and I am concerned on a longer-term basis about engagement of people and just the peer-to-peer connections that kind of get lost in this environment. You know, I feel relatively connected with you all on a Zoom call, but it's not the same as all being in the same room. Yeah. And so I do think that we have to find the right balance for that on a long-term basis.
Yeah, and you know, the reality is, yeah, go ahead, Dom.
I was gonna say, I think that's an excellent point Doug makes. We've all kept our productivity good. We're getting the work done. But some of it is when the pandemic hit, we all scattered, worked remotely, but we all knew each other as a team. So you had those relationships and can keep things going. How do you maintain that going forward as there's turnover in staff and bring new people on board, and you have to address what's your onboarding activities? How do you get that culture instilled?
Absolutely. So there's culture impacts. There's things that, you know, it's going to play out over months and years, and as a kind of a significant experiment. You know, I've read some studies where, you know, organizations have, you know, tested this environment, and they ask people who wants to work at home, and they you know, X number of people wanted to work at home. This is not in healthcare, but just general business. And after like 6 months, they went back and asked them, you know, how it was going. And a bunch of them, you know, after an extended period of time, were saying, well, I'd like to be back in the office. I'm kind of tired of being at home. Of course, then there's the way our society works. There's different impacts on moms versus dads. And, you know, it's just it's going to be a fascinating environment to watch over these next few years to see how, you know, how we recalibrate to a balance on that one. So
yeah, I just think about this. I've come into the office every day, so I haven't had the work at home environment personally, but I do know on the handful of days that I have worked at home over the course of the last year, you know, you're isolated. You know, it's definitely different. I'm not sure I would like to be at home for the last year, never seeing anyone getting out, breathing some fresh air, getting in your car and going to work. It's part of just the habits we have as humans that, you know, actually I kind of like.
Yeah, you know, it's interesting. I have a couple kids, but my son, who's married, he's a pastor at a small church, and so he loves people, right? So this has been driving him crazy. His wife's more of an introvert, and she says, you know, and she's got 2 cats sitting on her lap all day long. She's working, you know, remotely. She says, I think I'm just about the right number of people in my life right now. So, you know, you get the full gamut, and you know, when you employ thousands and thousands of people, you know, you're going to get a wide range of perspectives on that. So fascinating. Hey, there's a question that's been posted. that is actually related to where I wanted to go next. And the question is, and then I'll ask you my question, because it's interrelated. The question is, has the pandemic affected your transitions to value-based care? And where I wanted to go with this is, the pandemic has been an accelerant for some issues. You've heard that 1,000 times. It's exposed some other issues, and we've read about that. Things like, and I saw that there was a study recently about health disparities, and this is a study that was done by or published in the JAMA Network Open in January about racial disparities in mortality rates were larger in Chicago than any of the 30 major cities studied. If you look at that along with other things like chronic conditions and how we manage those, and um, or just globally, social determinants of health, that term that we talk about so much, food insecurity and unemployment and discrimination, all these things that contribute to people's health. And they're not unique to Chicago, but Chicago got their their own twist on it. And the reality is, we as an entire health system, not just health systems proper like your organizations, but the whole health system, health systems, health plans, the business community, public health, frankly, we've not managed our chronic condition environment very well. So again, so I see where that ties into perhaps value-based care. So can you just talk about, what do you see of the main obstacles improving outcomes in chronic conditions? Do you tie that to value-based care? Are you looking at value-based care differently than pre-pandemic? And I know I'm asking this very broadly, but it's a broad issue. So maybe Dom, I'll start with you. Just, it's a broad issue. I'll start with the biggest geographic area covered first.
Certainly, in terms of our approach to value-based care, it has not changed. The pandemic has not changed it. We do believe value-based care is good care, and being able to coordinate the care is going to result in better health outcomes. So we want to continue down that path, and put ourselves at risk for managing the health of populations. We've entered into a joint venture with an insurance company in Wisconsin that's going to expand more of our value-based care and risk business as we pursue Medicare Advantage and commercial risk-based lives. So our approach has not changed, and our strategic plan, really, prior to the pandemic and now, has not changed. Where we're headed. The pandemic and the social determinants of health that you addressed are important issues, and we need to figure out how we can all do a better job addressing those issues. Our governance has now established a board level diversity, equity, and inclusion committee of the board, and it's broad based. One of those areas that are being looked at is what's the health outcomes of our various populations, and breaking that down by Black and Hispanic and white folks, and how does that break down by age categories. So it's broad based. That's one of the areas that this committee is going to be focused on, and we're looking to target a few different chronic conditions, hypertension, diabetes, being a couple of those areas. And the Diversity and Equity and Inclusion Council is also establishing goals and targets for management, not only in the area of business spending, but what are our team member engagement scores broken down by different classes of individuals, and do we have the same percentage of persons of color represented in our management ranks as we do in our workforce as a whole. So there's a lot of different pillars that go into social determinants of health, and we're trying to touch on a number of those. We've made commitments to invest money through the Health Anchor Network to put $50 million to work in our communities over the next 5 years are just some examples in this space. And maybe I'll stop in the interest of time, and it is a broad range, and there's perhaps other areas that Rich or Doug want to comment on.
Well, I would just add to that briefly that our organization is likewise really stepping up our attention to the issues of health equity, access to care, the disparities between, particularly with chronic conditions, and access and disparities between various portions of the population. And as in sort of typical finance guy fashion, I'm very much you manage what you measure, and you manage and you improve when you set goals. And we're much more focused on this than we were a year ago, as it relates to health equity and and access to care. And we recognize that that the efforts that we have around population health and value-based care actually feed into that and help us to be better in dealing with those. And so we're really, although the pandemic may have taken our eye off the ball a little bit in the short term, we're really redoubling our attention to value-based care, our focus around how we use that and how we use population health to not only improve the general health of our community, but really addressing those individual component parts, which are really radically different in portions of our communities. That is startling when we start to peel back that onion.
I would just, augment what's been said. As far as our commitment to value-based, that hasn't changed. It's been a little difficult though when you think about well child visits or annual physicals for people who are afraid to come in, like elderly and your Medicare Advantage. So you're doing the best you can, but there is a certain amount of fear of people getting out. And Dawn mentioned children in particular. I mean, our pediatrics program volumes are down. There's, fortunately with the social distancing, there's not as much flu and influenza, so that's part of it. But so I think that is the future. I think the social determinants are real. When I was in Boston, I was a CFO of the Boston Medical Center, which is Stroger in Boston. And, food and housing insecurity. We had a Medicaid health plan, about 325,000 members between Medicaid and subsidized exchange products. And lots of times they're in the emergency room with ambulatory sensitive conditions. Why? Because they don't have a home or they have food insecurity. So I think these are things that are gonna, if we really want to put an inflection point into poverty, I think we have to deal with social determinants and, just transportation and employment opportunity and behavioral health is a huge issue. I think the issue that we have as healthcare providers, like I said earlier, if you're sick, acute care hospital, we make you better. We deal with crises, and now we're asking, okay, now help me manage my health. And so, if you decrease utilization, the insurance costs benefit. And, so you're asking providers to decrease utilization and also decrease their revenue. So that's the paradigm we have to figure out, and whether or not we should be insurance companies. And there's certain people will say, look, you need to be on the financing side and on the delivery side and get a certain margin on your net of your medical loss ratio and your administrative loss ratio and a contribution margin. So these things all have to be figured out, but social determinants really do determine kind of the health status of a big swath of the population.
Well, we all hope that there's some good things that come out of all of what we experienced as a society in 2020, and And Doug, I'm with you. You know, if you start with data, you know, it doesn't solve all these issues, and it certainly doesn't fix some of the emotional side of some of these issues, but it gets you to a point where you can have a fact-based conversation, and I think you can go from there. So that certainly resonates with me. You know, like most of these panels, I got to about 60% of the questions I wanted to ask. And again, we could go all afternoon, but Meghan won't let us. And so I just want to thank you guys for your honesty, your candor, your willingness to spend some more time with the group today, and sharing your thoughts. So thank you so much. And thank you, Meghan, for allowing me to host it. I really was humbled to do that. I'm really impressed with these three gentlemen, and I'd do it any day of the week. So thank you.
Well, thank you, Joe, for moderating today's discussion and for your team support at HFMA for helping us put today's program together. It was incredible. And many thanks to our panelists, Dominic, Richard, and Doug, for your time and thoughtful insights during our discussion today. And as usual, we can always keep going, but I figure everyone's done with their lunch hour and probably ready to get back to whatever their office may look like. For anybody following along, the recording and recap for this will be available on our website within the next few days. So if you want to share it with anyone, you can do that. Additionally, I encourage you to check out more information about our upcoming events, including our next Transformation Series event, which is this Tuesday, March 9th at 11 a.m. Central Time, which will be presented in partnership with HC3 member Ziegler to talk about decentralized clinical trials. So you can learn more about that and everything on our website, hc3.health. Thank you all again so much for your time and have a wonderful afternoon.